Yeah, so good afternoon, everyone. It's a pleasure to be here once again to talk about something that's important to society. It's the fourth in the series of our quarterly webinars for public education. And the topic for today is spectacle use in children, corrective or damaging. Right, so I'll start with a question. I'll pose a question to everyone. Did you know that all over the world, an estimated 19 million children are visually impaired worldwide? And 2/3 of these children are impaired simply because of what we refer to as refractive errors. Now, a refractive error is simply the inability to focus and see clearly. This can happen for distance or for reading or near. And it is estimated that 1 in 4 children in the classroom have some sort of visual difficulty, whether or not it's known to you. Now, what are the types of refractive errors that we can find? And I'll start by saying that whether or not you will have a refractive error and what type of refractive error you have is determined basically by the length of your eyeball, how long your eyeball is, as well as the curvature, the way the surface, as we all know, the eye is a curved structure. So the way in which it is shaped also determines what sort of error you have. And so we have, most people have no error at all. And then you have people who are short-sighted, also called myopia, which means they have an inability to see clearly afar, but they usually can see, up close. And then you have the inability to see afar, I beg your pardon, near. That's long-sightedness, also called hyperopia medically. Then you have people who have an irregular error, which we call astigmatism, in which case combination of different types of these errors. Now, so this is an attempt to illustrate to you for better understanding the determination, what happens really when a person has an error. And so the picture to the extreme left is a normal situation. That's a normal eye with no error. And so you see this eye is looking at some fruit. Is that an apple or a pear? But this eye is looking at a fruit and you're being shown what happens inside the eye. So there's a layer at the very back of the eye, just in front of the nerve of the eye called the retina. And this is where an image must sit if you have to see clearly. So this is a normal situation. There's a certain length of eyeball. If you can measure the eyeball, and we have machines that can do that, what's obvious to you when you look at an eyeball is what's in front. But we have machines that can measure the whole length up to the back of the eye. So if you have a certain length of eyeball for age from the front to the back, then this is where the image would be, and this is normal sighted. In a short-sighted person, that's the second picture, you have the eyeball too long. So if you're short-sighted, most of the time, your eyeball is too long, and therefore you have the image falling short of where it should be at the back of the eye. The opposite is true for long-sightedness. That's the very last picture, in which case the eyeball is too short. In a long-sighted person, the eyeball is too short, and therefore the image overshoots, like overshooting the tarmac. And so this image overshoots and doesn't sit on the retina, it's behind the eye. Then you have astigmatism, which is an irregular error. That's the third picture, in which case you have more than one image. So this eye sees the image differently when it's looking vertically versus when it's looking horizontally. And the total effect of this is that the images are all irregular. Now, this again is another picture illustration that just shows, a picture illustration that shows what you see when you're in the consulting room. So when you come to see the doctor, you can see when you're looking at a chart, a vision chart, which is what you can see. If you're normal sighted, the chart would be seen on the retina. So you can see that in picture 1, that chart is sitting on that red surface. And in picture 2, why is it there? Picture 2, it's a short-sighted eye, and you can see that it falls short. It doesn't get to the retina. With picture 3, it's behind the retina. That's a long-sighted person. And in picture 4, it's irregular. There's more than one image. Now, how can you tell that a child has a refractive error? So sometimes a child can have blurry image. The image is blurry. Sorry, just a moment. The image is blurry. That is in children who can verbalize. So they would tell you that the image looks blurry. They're unable to see clearly or hazy or whatever. Now, not all children can verbalize and actually tell you that their image is blurry, especially for children who had never had a different experience. And so sometimes it's the slow pace of copying notes in class that tells you that there might be a problem. And so if you have a child who is particularly slow, one of the things you must consider is that perhaps the child cannot see the board properly. And then the closest to the board, you know, sometimes you have children wanting to always be close to the TV, close to the board in class, putting the books very close to their faces or other devices. This is an indication that a child is likely to be short-sighted. And then when children just have a general disinterest in academic work, it may be because they can't see clearly. So if you're sat wherever you are in class and the board is all blurry, although your book is blurry, you become disinterested. And so sometimes disinterest in work can signal that there's a problem. It might be a refractive error in the child. There's still many other symptoms you can have. Sometimes children are skipping lines while they're reading or copying. So they're skipping lines. So this may mean a refractive error. Sometimes they're substituting letters. And so a child might see an A, a small letter A, and call it an E, or see an O and call it a U. And so if that's the case, you should suspect that this might be the problem. Sometimes children have eye aches and headaches, constantly complaining about pain in the eyes and the head. It could be a long-sighted or an astigmatic child. And general inattention in class. We've already alluded to this. Squeezing the eyelids while focusing. So sometimes you see a child actually squeezing together the lids while trying to focus on something. This definitely means there's a refractive error. Sometimes children with refractive errors are constantly or intermittently shutting one eye or the other. Again, if a child has a squint, and everyone, well, perhaps some people know what squint means, which means the eyes are not looking straight ahead in the same direction. And so a squint can mean that a child has a refractive error, or a squint can happen because a child has a refractive error. So they can be interwoven like that. Sometimes children report seeing double. This may also mean that they have a refractive error. Sometimes you might see that the child has some abnormal eye movements. The eyes are moving, shaking back and forth, up and down, side to side. This is indicative that this child is likely to have a refractive error. So these are the various things you can see that is a pointer to refractive error in children. What are the consequences of visual impairments? I mean, if you can't see well, then the first thing that will happen, especially if it happens early in life, like in infancy, is there'll be a delay, either poor early development or delay. And so some of these children are reported not to sit on time, crawl in time, walk in time. For indeed, how can you take that step when you can't see where you're supposed to be stepping on? And so if a child has poor vision, it will affect their development. Again, when they get to the class age, school age, you will find poor academic performance. We've already told you about blurry. So if you can't see the board and you can't read your books for a long time without having a headache or discomfort, then it's going to suffer. Your academic performance will suffer. And so a good deal number of children who are thought to be dullards simply cannot see properly. Their performance takes a totally different direction once you give them glasses. And so poor academic performance might be indicative of visual impairment. Of course, if you're thought to be the dullest person in class, or you cannot adequately participate in class, or it'll affect your self-esteem. So a lot of the time, children get called names cruelly because they're slow academically or because they have a squint. And so people have all sorts of names. And so this all just leads to poor self-esteem in a child. Of course, if your academic performance is affected in class, this will limit your success with future attainment, because we're an educationally based society. So if you have to get into tertiary institution, you have to have performed well in secondary. So if you have limited performance, this limits your success with getting a course, and with future attainment and even performance in the office. When you get to the office, I say this because some of the visual disturbances children have, if not quickly attended to, might lead to a permanent visual disability. And so this will affect their performance later as adults in life. Naturally, this has economic consequences for the person and for society, because this is a person who is supposed to be contributing to society and to nation building. So visual impairment exacts a huge toll worldwide, estimated billions in dollars worldwide, because either from lost wages or from the sheer amount of money you have to spend to bring up a visually disabled child, estimated to be up to 6 times higher than if you had a child who was not visually disabled. Now, the solution to refractive error is spectacle wear. And so I brought this illustration here just to help you understand how spectacles, what they really do for you. And so you can see in the top pictures are illustrated the 3 major kinds of refractive errors. The short-sightedness, and I told you the image doesn't get to the retina. So you can see in the top left picture, the image of the person the eye is looking at has stopped short. So if you look at the bottom of that picture, the lens that in between the eye and what the person is looking at helps you to appropriately place the object on the retina. So you can now see the images on the retina. The middle picture is of long-sightedness. So the image in long-sightedness, the eyeball is short, the image has overshot the retina. Again, the lens that you use would help you place the image right onto the retina. And then the same thing in an astigmatic person. So we have a special set of lenses we call cylinders, which help you to merge the irregular images when you have an astigmatism. So really, wearing of glasses, spectacles with glasses, is the solution for refractive errors in anybody, and children are not an exception. Now, I will need to emphasize, because I get asked this question a lot, so I need to emphasize that eye drops cannot, will not treat unclear vision if the cause is a refractive error. I get asked this a lot. Can't the child use eye drops rather than glasses? The answer is no. Eye drops is not, an alternative. Neither is diet. Again, I get asked, how about if the child takes a lot of vitamin A and eats lots of carrots? So again, I say to you, it's good to have a good diet, but this does not substitute as treatment for a refractive error in anybody. And so let's go through some of the facts and fallacies, some of the, the truths and the falsehoods surrounding spectacle use, in children and I guess in everybody else. So spectacles help you see better when you have a refractive error. That's a fact. And you can see that just as I showed you in the previous illustration. So a person is long or short-sighted. Your lens helps you to place the material where it should be, which is on your retina. And so you see better. So this child will see better. It's a fact. Next thing, it is thought, some people think that spectacles, correct your error such that you will no longer need them after a while. Now, this is not a fact. This is a fallacy. It's not true. And this is the opportunity. This creates a fantastic opportunity for us to attend to this very confusing situation, because I get asked all the time, my child has been using glasses for 5 years. The doctor had told me it was a corrective pair of lenses. Why hasn't he corrected? And so this is a time to make everyone understand where the confusion has come from. So corrective is a technical term for the eye practitioner. For the eye doctor, the word corrective simply means what you can see when you have your glasses on. It doesn't mean anything more than that. And so if you look at this picture, this illustration here on your screen, you can see through the glasses, the letters are sharp. Outside the glasses, that's the person's view. If he wasn't wearing the glasses, it's blurry. That view, that sharp view with the glasses is your corrected vision. That's all it means. Unfortunately, it has another meaning in English, because in English, corrective means the problem goes away. But that's not the technical meaning for the eye practitioner. And so understand that your corrected vision is what you can see with your glasses. Your unaided or uncorrected vision is what you can see without your glasses. And so I hope that this has now sort of, cleared the air regarding the issue of correction or no correction. It simply means what you can see with your glasses. However, let me say that there are children who outgrow their error. I said to you that children who are long-sighted have a short eyeball. Our eyes continue to grow as we grow taller. And so as the eyeball continues to grow, eventually it may be that it grows to the point where it's long enough for that image to now be on the retina. If this happens, then that child stops needing the glasses. Right, so the third thing to attend to is that children can be too young to wear glasses. This is an absolute fallacy. And I have brought to you just a few out of hundreds of children that we have who wear glasses. And so you can see that we have children here between the ages of 5 months The child on the top left corner is a 5-month-old, and all the way to 3 years. The oldest child here is a 3-year-old, 2.5, 3-year-old. And so it's not true that children are ever too young to wear glasses. It just depends on what the problem is. And it's the most important thing is for a child to use glasses earlier when they do need it. If they don't, the eye or eyes become what we call a lazy eye later in life. So if you give one eye, because sometimes children's eyes are unequal. So you might have a child with one absolutely normal sighted eye and another eye is not. So the brain knows that one eye is supplying clear images and the other is not. So what does the brain do? It shuts down off the weaker eye. We call this amblyopia. If you have children with very high errors, both eyes, the brain will shut off both eyes. And so if you don't intervene early in life with glasses to clear the vision and make the eyes equal, the brain will eventually stop working with the eyes actively, and this person is likely to have very limited vision going forward as an adult. Now, also, some people believe your eyes will get worse when you wear glasses. This is not true at all. Now, when you're a short-sighted person, you're short-sighted because your eyeball is already too long. You're born with an eyeball that is long. And so already the image is already behind, stopping short of your retina. Now this person will grow taller. I told you earlier that the taller you get as a child, the more your eye grows, the longer. We all know our eyes when we were 2 years old isn't the same size it is now as an adulthood. It has grown. Therefore, when a short-sighted person who already started with the image not getting to the retina grows taller, the eye grows longer, they get more short-sighted. When they get to teenage years, when our vertical height growth reduces, naturally the eyes also stabilize, and then you find out that it's not increasing as much. So whereas the long-sighted child can outgrow their glasses, the short-sighted child will continue to be short-sighted and more so. That is a natural course of events. Also, people believe that spectacles will make your eyes sink deeper. This is not true at all, because I think what happens sometimes is, especially for when people are long-sighted, the kind of lenses they use are thick and they magnify the eye. So when you look at such a person, the eye looks large. So when they take off the glasses, sometimes you look at them, the eye suddenly looks smaller, because the glass isn't in front of the eye to make it look, like a magnifying glass. That's what might give this impression that your eyeballs sink deeper. There's nowhere to sink into, really. There's a fat pad. Your eyeball is sitting down on a fat pad, and unless if a person has a severe injury or something, the eyes don't, or has an eye that has cut open from injury, the eyeball doesn't sink anywhere. So it's not right. Now, the power of your lenses weakens after a while. This is a fact, because especially in childhood, like I told you, the child keeps growing, and as they grow, the eyes change. So we have to keep up with the changes. So it is true that after a while, you find out that even for adults at a certain age, that the lenses are not as sharp, the view, as when you first got them. So this is a fact. Also, that refractive errors can be inherited. Absolutely, it's a fact. Just like every other characteristic we have, we inherit from a huge family gene pool. And so if the person whose eyeball length characteristic you inherited has a long eye, you'll be myopic, you'll be short-sighted. If the person has a very short eye, then you're likely to be long-sighted. If a person has astigmatism, you're likely to have astigmatism. So sometimes you find errors in children that you don't find in their parents. That's because when you inherit characteristics, you don't necessarily inherit strictly from your parents. Anyone in the family, probably a distant family member you never met. So it's a huge family gene pool. And so if you pick the characteristics of someone who is long or short-sighted, then you will be too. So that's a fact. Now, it is not okay to obtain glasses from roadside sellers or shops. Everyone must get properly tested in hospital. Now, there are important points to note, regarding children. Now, children are unique, and their visual impairment may not be obvious because many of them don't have a different experience. We have children who have had blurry vision from infancy. They don't know any difference. They don't know things can be clearer. It takes a mature child who has had clear vision previously to actually verbalize and tell you. So they are unique like that. They need to have their eyes checked because the problems are not always obvious. And they need to have this eye checked very early in life, very important. And if your child as a baby, even if it's a newborn or a few weeks or months old, if you notice a large eye, one eye, the eyes are large, or one looking larger than the other, like they're unequal, or an eye strikes you as small or smaller than the other, or you see a whitish or yellowish shadow from inside the black part of the eye, or your child has a squint, which means the eyes are not looking in the same direction, or the eyes are looking hazy, the black parts of the eye looking hazy or watery or bulging, immediately is when you should have this checked out. You don't wait. Now, should you not have any of this, ideally, you should think about giving your 6-month-old infant a routine eye check. Now, if this doesn't happen, then certainly in the preschool years, by the time the child is 3 years and ready for kindergarten, you should know if this child is normal, long, or short-sighted. Absolutely important. And after this, yearly, on a yearly basis, you should check. Children have rapidly growing eyes as in the first few years of life because they're growing taller very quickly. So until they get to about teenage years, we need to keep checking yearly, and then we can stretch out the period afterwards, as advised by the ophthalmologist. And I want to emphasize that you're having your children's eyes checked, see an ophthalmologist. Very important. That's a comprehensive eye specialist. I want to make a special note about albinism. Children who are, born with albinism. Albinism is a situation where a person lacks the melanin pigment that gives our skin and eyes and hair the darkness. And so this is an illustration of a baby. They have completely different development in their eyes. So right from the womb, the child who genetically has albinism, right from the womb, the eyes develop differently, such that they are guaranteed to have visual, problems from the structural differences they have. There are no exceptions. Every single child with albinism has visual difficulties, and therefore they need to have their eyes checked absolutely early in life. By 3 months of age, they need to start checking, and very frequently thereafter. Probably shouldn't be yearly. This should be probably 3 monthly or 6 monthly in this case, because of the special situation that they have. And so it's important to ensure early spectacle use. That's their best chance to have reasonable vision, because they have many other issues with their eyes. And so we need to take the refractive error part out of it so they can end up with reasonable vision that will allow them education and function reasonably in life. Now, other important points to note is that we've already said that parents need to allow spectacle wear at whatever age it is recommended. They're never too young. Diet and eye drops are not an alternative. It's important to know that. And follow exact instructions as given. So if this child is supposed to wear the glasses all day long, please let them wear it all day long. Don't keep deciding about people. Sometimes are embarrassed about their children wearing glasses. I cannot understand why, However, we have situations where parents are denying children spectacle use when they're in public, and they let them wear it when they're home. That's inappropriate. It doesn't allow for proper visual development. And so if your doctor has advised that this child needs to have the glasses on all the time, they need to have it on all the time. This is very important. Update the prescriptions as required. You'll be advised. Is it 6 monthly? Is it 9 monthly? Is it every year, a year and a half? Your ophthalmologist will advise. And then there's something called patching therapy. So sometimes you have children with unequal eyes. One eye is clear, the other eye is not. And when this happens, we call it patching therapy. We patch the better eye so we can give the weaker eye a chance to connect to the brain for a certain number of hours. Again, this advice comes from the clinic. And oftentimes children resist. Parents need to know that this is the only way this child's eye can be put up to scratch with the better eye. And therefore, if you've been advised patching, you as a parent, you need to do all it takes, be very firm with the child because it's for their good. So patching therapy, very important to comply when you need it. Now, children with albinism should ideally have photochromic lenses, because part of the challenge of not having this melanin pigment is that they have glare, which means that they're very, very sensitive to lights. And so under the sun, they have difficulty seeing when the lights are really bright. And so the kind of lenses are photochromic lenses are what are ideal for children with albinism, because it will change itself. It will get dark when you're under the sun. It will lighten up again, bleach out again when it's not sunny. Now, screen time. So let's talk about screen time, which is a very important now. There are devices all over the place. Children are not exempted. We see even babies with devices. So there are many studies, many researches that associate screen time with development of short-sightedness. and also that it can make short-sightedness accelerate faster than it should. Remember I said that short-sighted children get more short-sighted as a natural matter of getting taller and the eyes getting longer. However, screen time has been associated, excessive screen time, and so a child may end up very short-sighted, more short-sighted than they should be if they're on the screen all the time. The American Association of Pediatrics has recommended, what they think is appropriate, to stop this from happening. So children less than 2 years old should not be on the screen at all. So if your child is less than 2, they shouldn't have any business with a device, ideally. Children between 2 and 5 years of age should have 1 hour leisure time on the screen, 1 hour. We already know that many of them are involved nowadays with screens in school academically. And so for leisure, you shouldn't have your 2 to 5 year old spend more than an hour on the screen. Your 6 to 17-year-old, 2 hours. And so as difficult as it may be, this is what will benefit the children visually. And so hopefully sites like this should become, non-existent, I hope. Now, again, still with our important points to note, we've talked about photochromic lenses. They're usually not routine for children, especially under tinted lenses, because indoors the tints become a disadvantage. But I have said that we reserve this will be required, cared for, then it becomes irregular. The coating becomes irregular as it should. Take care to clean your lenses as required. Dots, smudges, fingerprints, and children handle their lenses. They're immature, so they handle their lenses all the time. So they're always leaving smudges and fingerprints. So we have to pay good attention and have it cleaned every time it needs to be cleaned. And when you clean it, clean with a microfiber or a soft cloth, not just any other cloth, because otherwise it will scratch. And it's better to wet your lens. It's always best to wet your lens with a lens cleaning fluid before you clean it. That makes it, nice and clear. Now, use cases for storage to protect glasses. A lot of children lose, and even adults lose their glasses from not putting it in a case. It gets scratched, it gets broken, it gets stolen. And so you need to use the cases whenever it's not being used. This avoids loss and breakages. Frames for customized children. I beg your pardon, customized frames for children, because we have situations where people try to manage adult frames for children. Now, this is totally inappropriate because there's something called centration. The center of the child's eye should be looking through the center of the child's lens. That's the best part of the lens for vision. And so you need to have your children use frames that are actually customized pediatric frames for best fit. That's important. The frame shouldn't be too tight. It shouldn't be too loose. That's important. So you don't want it falling off, but you don't want it tight such that the child is uncomfortable, it's eating into the skin and giving them pain at pressure points. And then I also want to say, parents, please, children love colors. And they're the ones who will use the frame. They're the users. Let them choose their colors. So children are more excited about complying with using their frames when they participated in choosing. The child wants a pink frame, please let them have a pink frame. They feel good about what they're wearing. There's a psychological aspect to spectacle wearing in children. So if you choose the color, because parents love bland colors, brown, black, this child doesn't feel happy about it. And you know what happens when they come into class? Other children laugh. I don't know, it's not funny, but they laugh anyway. And especially if this is a first child to wear, in class, they're going to be very sensitive. They will take them off. They won't use it. So please let them definitely be the ones to pick the colors of their frames. This is extremely important. So I would like to summarize by saying that children often have defective vision in one or both eyes. It may not be obvious to you, but it needs to be discovered early. Late discovery may mean permanently low vision for life, and spectacle use gives you clear images, thereby allowing optimal development of visual functions. Comfort and consistency of use are extremely important for progress, and spectacle use may be discontinued when the ophthalmologist advises that that's the case. So I will conclude by saying spectacle use in children is definitely safe. it is helpful, and it's important to begin early in life when it's required. Thank you very much for your time.
Yeah.
I'll be happy to answer any
Now
questions.
The question and answer section. So if you have questions, please, you can post it on the chat.
I think people can unmute themselves if they would like to ask a question.
Okay, that's true. So you can unmute yourself. And Dr. Alimi, you can answer some of the questions on the chat.
Okay, so thank you for the question. Someone has asked a question regarding a 5-year-old whose eyes at times looks like it's crossed. Should you be worried? Well, yes, you should be worried. That's the squint, and you need to find out what the cause of the squint is. And we also need to treat the squint, because as you have seen, it is treatable. You saw a picture of a child with crossed eyes after surgery. It's not always surgery. Sometimes it's glasses, sometimes it's surgery, sometimes it's a combination. But what is important is you need to have it checked out. So you need to see a pediatric ophthalmologist to have this checked out so that it will not develop the longer you wait. Okay, somebody has a hand raised. Go ahead and unmute yourself.
Okay.
Unmute yourself.
Please.
Hello, can you hear me?
Yes, please. Go ahead.
Assalamu alaikum.
Alaikum salam.
Thank you so much for the lecture. It has really been insightful for me. I have 2 questions.
Right.
My first son is 7 years plus.
Okay.
It was around 3 years ago. So the teacher complained that it seems he couldn't see the board very well.
Okay.
So while checking his handwriting as well, I observed that as he writes, he misses words together. Though he's quite intelligent, alhamdulillah, he knows spelling, but sometimes when he writes, the writings are not the same with what is on the board. So we went to the high clinic. So when they did the test, the doctor that attended to us that day, she was like, I've really delayed this thing, that the sight has really gone very low, that it is too low for his age, that he's short-sighted. So I was worried as the mother that what could have been the cause? Where did I get it wrong? So she now said he will be using glasses, though he's using it and it has improved. His writing has improved. But where I am concerned now is even in the house, he doesn't need to write. My boy will go and pick glasses and wear. So I will be the one to tell him, do you need to wear it? Is it every time you should be wearing it, even in the house? So I want to know, is it that I should be wearing it every time? And is there anything I can do to improve that sight? Because I was told that the older they get, the worse it becomes. So that is one. Then my second son as well, I observed that he is a 3+ now. If he is watching something, like he's watching TV or something, he normally squeezes his face as if he's straining the eye to see. So I don't know if you get my questions, ma.
Yes, I got your question. Right.
Okay, ma. Okay,
yes,
ma. So those are the 2 questions I have, ma.
Okay, so I'll get to it. Thank you for your questions. Okay, now, from what I've told you today, you probably, you already understand better, what's going on with your boy. He's short-sighted.
Yes, ma'am. Yes,
He's better once his glasses come on. That's why he keeps putting it on. The short-sighted children, you don't need to convince them to wear glasses. The moment they put on the glasses, they see the world looks so much more beautiful than they thought. So they put their glasses on. That's why you see him wearing it. You should absolutely let him wear the glasses. He should.
Okay.
No okay. And don't use the word worse, because you make it sound like a disease. It's not a disease. It's just the eye characteristics. Obviously, it's genetic. Like I said, he has inherited that characteristic from somewhere in the family tree. It's not a disease. We were created in all different ways. His younger brother is manifesting. You just said it yourself. I listed it as one of the features of a refractive error. He's already going close to the board or to the TV. That tells you he's also short-sighted. The right time for him to start glasses is right away. So you need to go and properly evaluated and let him and know that as they grow older, as they grow taller and the eyes grow longer, the short-sightedness will increase. Therefore, you have to keep changing the glasses. A year at this age, older, maybe a year and a half. Okay, but don't use the word worse. A refractive error is not a disease at all. It depends on the length of yes. And though you didn't do anything, even if you had been the short-sighted person that he inherited it from, that is what was destined to happen. It's not a disease. No, there's nobody at fault. Let him use his glasses.
Yes.
He'll definitely perform better.
All right. Okay, Jazakallah khairan.
Okay, chat. Okay, question in the chat room. Just a moment. What is it? Right, okay, so I've seen questions in the chat room. If eyeglasses can be substituted with contact lenses. Contact lenses, even though they are an optical choice, they are not routine for children. That's because they're not without their potential problems, even for adults. So contact lenses are, as you know, you put them right on top of your eyeball. So that's a foreign body on your eyeball. And so there are all sorts of things that can potentially be associated with contact lens use, from infection to inflammation to allergies, you know, all sorts of things, to ulcers on your eye. Those are all potential complications. Children are not as careful as adults. Besides, contact lenses can fall out. So if you have contact lenses in your eye, you can lose them. If you accidentally scratch your eye, you know, you're unwary and you scratch, the next thing you know, your vision is blurry because the contact lens is out, it's falling off. And it's a tiny little thing like a cellophane. So you're never going to find it, you know. And so it's expensive to maintain for children and it has potential problems. And therefore, the safest way is still your glasses. It's still the most uncomplicated way, especially for children. And especially if you're in the tropics, because our weather favors bacteria. It's wet, it's hot, and so perfect conditions for microorganisms to flourish. And so the tendency for infection quite high. And so I wouldn't advise at all. And then the other thing is patching therapy when it is necessary or needed. Yes, that's when one eye is much stronger than the other. So what we do is we patch the better eye. There's a certain number of hours, you know, it's done every day. And in that period of time when it's patched, the good eye, the brain connects with the weaker eye and gradually, you know, it's in the absence of any other severe problem with that eye, the vision gradually gets better. Children patch for as long as 6 months to get the desired results. And if it's well done, it's quite good. Someone wants to know if refractive errors can be corrected with laser surgery. Well, so yeah, if you look it up, there are places in the world where people, you know, you see it advertised all the time, do a laser procedure, throw your glasses away forever. But it's a gamble. It's a gamble. Certainly not in children. Let me start because I'm talking about children here. Certainly not in children. Children are actively growing, so you do not do that with them. Even for adults who choose to do that, it's a gamble. So things can go wrong. And if it goes wrong, it goes permanently wrong. And so oftentimes as a practitioner, people ask me, should I have laser surgery? My answer to them is, do you gamble? So are you willing to be on the bad side of the gamble? Because then there'll be no solution. You can't go back to glasses at that point. And so it's not something that I recommend at all. I do not recommend laser refractive surgery as a practitioner. I think there's still another question. Somebody says she's been wearing glasses for 15 years due to astigmatism, and she's wondering if you can correct the error. You know, now, so again, I clarified the word correction simply means what you can wear, what you can see when you have your glasses on. So it will correct your vision while you have your glasses on. What you can see is clearer. That's your corrected vision. The moment you take off your glasses, you're back to your eye. So it doesn't make a difference with your eye. It only makes a difference to the vision, what your eye can see when the glasses is put on. And so, no, the word correction has been misunderstood. it's not the English definition of correction, I'm afraid. So somebody, yeah. I did it, I said the opposite. You know, I said your glasses get weak. You know, what I said was the opposite. Somebody has asked that I mentioned that glasses don't get weak. No, I said the opposite. I said your glasses get, I said it's a fact that your glasses get weak over time, both as children and as adults. You have to change your glasses after a while because the eye moves on and leaves that power behind. So you now what we call spectacle intolerance. It no longer matches your eye, and then you have to change it. So it does change. Somebody wants to know what's the difference between refraction and midrasil refraction. Okay, midrasil is an eye drop that we use to dilate. Dilating the pupil, the hole in the eye through which we carry out the test is called the pupil. Sometimes a child's pupil might be very small, and so we can't really see, the machine is unable to measure. So sometimes we artificially enlarge the pupil. It's a temporary enlargement with an eye drop. And once the drop is in the eye, after 30 minutes or 1 hour, that hole is wide enough for us to do the test and get the results. Typically, the effect reverses in 4 hours after the test is done. So that's what midrasil refraction means. It means a drop had to be put in the eye to help dilate the pupil. Yes, yes. Abdulatif's iPhone, you have your hand raised. Please unmute yourself and ask your question.
Jazakumullah khairan for the insightful education. So my question actually is for the sister who covered the advocacy and the reach of the organization. So do you like kind of provide any tools for the teachers in the schools? So what do they do after training them? When they spot that a child is struggling, what do they do? Do they like refer them to the hospital? Do they like take anything? Do they do anything? Do they need any tool to support the kids and get them to receive the treatment that they deserve?
Okay.
That's one of the questions. Do you want to answer that first, or should I ask all the questions?
Ask all the questions.
Oh, okay, so that's the first. So the second is what percentage of the kids have issues in the population you have met, you've examined? So how rampant are issues, and what are the what was the pattern like? What are the common issues in the kids, and how spread is it in terms of population wise? When you do this, and I'm very happy that you do the treatment for them and everything, but do you do following up with them after 6 months of having a treatment? Did they get better? Did they get worse? And do they still continue the behavioral changes you're introducing to them in terms of wearing the glasses and everything? Do they still continue with that? Because that's gonna help strengthen your program plan, right? And the last one is for the trainer program you do. Is there a way you can maybe develop learning aids, video tutorials or something? Because I'm looking at the scale, if you want to do that for all the schools in Lagos State, let alone going to Ibadan or going to other places in Nigeria, that's going to take a lot of resources off you. Are you looking at strategies to scale it through digital technology, please? Thank you.
Okay. Thank you very much. That's a lot of questions. All right. So the first one, do we equip the teachers? Yes, actually, that's a mistake on my part. For all the schools that we train, we give them a kit that enables the teachers to go back to their school and examine all the children. And we've had a lot of referrals. We encourage them that, okay, where the foundation is in Surulere, we've gone to the island, we've gone to Agege and places like that. So sometimes it may not be very convenient for you to refer all the children to us. We tell them to refer to any of the government hospitals, any hospitals around. So, but for some of them, they will rather come to the foundation. And so we've had a lot of referrals. I hope I answered that question. And for each school, they get a kit. We train the teachers, we get a kit. And the next step, now, maybe I just had this, is that in the next 12 months, we are organizing, going back to each of those schools they've gone. We want to go in and re-examine the teachers so that we are not giving kits to teachers who actually cannot see. So we are interested now in making sure that all the teachers also have their eyes examined. And We want to use it to encourage those schools that have not done. So we have started collating data. We started calling them on the phone. Okay, we came to your school at so time. How many children have you seen? Have you done this? Have you done that? How many referrals have you had? So I may not be able to give you in detail the percentage of children that have some high condition. For example, refractive error. Because after we have trained the teachers, it's not all those children that come back to us. But for those communities where we went to and screened all the children in those communities, yeah, I can give you an idea that the commonest condition you see is that they have allergies. Some few ones have some infection in the eye that we give medications for. Now, for some, like for some, sorry, I don't have all the data right here. We see there's hardly a school, a community we go to that you don't see 1 or 2 children that need surgery. Take for instance, I think I should remember that of Makoko. In Makoko, we had about five children. Dr. Alimi can help me correct that actually needed surgery and have had their surgeries done. So I hope I've been able to answer that to some extent. Now, okay. So I've answered the question on follow-up, that we are now planning on going back, and we've already started the process by calling those schools to see how far they've gone. Now, training the trainers and getting like videos is a good idea. We'll look into that and see how far we can go, because we know it's not a project for us alone. It's for everybody to do. And I'm sure we have other foundations trying to do something like that, but we'll actually look into that. Thank you. Dr. Alimi, can you add 1 or 2 things?
Yeah, thank you for your question. The follow-up, the question on follow-up, I'm not sure whether you are, to my mind, you are asking about the children. So the answer is yes. The thing about pediatric children is they need close follow-up, and they continue to need follow-up until adulthood. So they never leave you. And so yes, follow-up is important, because as a matter of fact, if you do check a child now and determine that that child is normal sighted, you need to check again in 6 months to 1 year, because oftentimes the problems evolve. And so a child's eye length, the eyeball length might be normal now, but it's grown longer in a year's time. And that child who was normal sighted now might become short sighted later. So the fact that you have a clean bill today doesn't mean you stop checking. So follow-up is a continuous process, even more important than in children, more frequent in children than even adults. And there are many other visual functions that we check. Beyond the actual clarity of vision, there are many visual functions that we check, which is why we keep saying see an ophthalmologist. That's important. Okay, yes. Sekina Jimo has her hand up, so please unmute yourself and ask your question.
Yeah, Assalamu alaikum wa barakatuh. Yeah, a very good job done there by Dr. Alimi and the Restore Eye Foundation. May Allah continue to reward you.
Amen.
I have 2 questions or so here. And the first one I have is that looking at the data given by Dr. Akeremi and the efforts being made so far, I want to find out if there is any way the organization is trying to influence the policymakers, especially in the health sector, to sort of, yeah, you can train the teachers, train all the necessary people, but then if the policymakers are not in tune with the ideas of the teacher and what you are trying to do, might sort of jeopardize the effort. So what is the effort you are putting forward to involve the policymakers? Either you take even the advocacy or the training down to them, so that get them screened and then educate them, and let's see how they also follow up and fall in line with the advocacy you are doing. That's number 1. Number 2 is, yeah, we have this enlightenment here on Zoom using the technology. What about those who do not have access to this digital development that we are using? The lay people in the community, in the marketplaces and all that. Is there any effort by the foundation to sort of get them involved and sensitize them to, the plight of eye errors in children and even in adults. And then the personal question, I realized that my eyes get watery, like teary, oftentimes, and I'm wondering what is actually going on. So those are the 3 things I think I have here. The last one, is there any difference between an ophthalmologist and optometrist? Thank you.
Right. Thank you for your questions. Right. So yeah, so part of what activities, advocacy is part of what Restore Foundation does. And yes, we're in a state where, the state also carries out eye health programs for children. And therefore, that's why you notice that the schools that we have been to are basically non-government schools. And so over time, to proper advocacy, you need volumes, and you need, to make a position paper, you need good research. And so over time, we're 14 months old. It's in the plan. If you looked at the 12 months, the next 2 years plan, you saw there, we talked about advocacy. So yes, we already started. We've been to the Lagos State Office in charge of disabilities, and we're already well aware of our activities, especially with the children with albinism, and going forward, other disadvantaged group of children that we intend to do things with. And so yes, we definitely plan to influence policy. What we would love to see is an eye health policy legislation for children that mandates that children have eye checks at a certain age, so that by law, it should be done. That's what we're hoping to achieve here. That's that. Now, you brought up a very important point about community sensitization. Those who are not on the Zoom, absolutely, it's a valid point. So yes, again, going forward, the information to the general. And so, yes, we intend to do this. It takes planning, but it's certainly in the works. Then you asked the questions about teary eyes. There are many things that can cause teary eyes, from allergy to very cold weather, extremes of weather, to, many things really. And if your eyes are teary, again, sometimes as we get older, eyes get teary. Teary eyes may be dry eye. I know it sounds funny, but sometimes your eyes can water because you have dry eye, and which means that the ability for the tears to stick on, the lubrication on the surface of your eye is no longer so effective. And so the brain keeps thinking the eye is dry, and keeps ordering the larger gland here to water. So yeah, it can be many things, probably needs to be checked out. Probably the easiest thing you could do is just use a regular ocular lubricant, which you can find over the counter anywhere, and see if that helps you. Right, so you asked the question, very valid question, what's the difference between an ophthalmologist and an optometrist? So an ophthalmologist is a medical doctor by training. So to be an ophthalmologist, you have to first go to medical school and acquire an MBBS or an MD degree. Then you go back another 5 or 6 years to specialize in the eye. The same way another person specializes in pediatrics and obstetrics and gynecology and orthopedics. That's the same way the ophthalmologist have to go back and do the eye. So you're a comprehensive specialist, medical, optical, surgical, preventive, everything. Now, an optometrist, School of Optometry, probably 3-4 year program, and your basic optometry is a Latin word. Opto means eye, metry is measurement. So measuring the eye. I told you about the length of the eye, determining whether you're long-sighted, short-sighted. So the basic thing that an optometrist would do is refraction. So if you're in a busy setup, when the ophthalmologist has seen you and determined that your problem is optical, they're busy, even though they can refract you, they send you to the optometrist to do your refraction. When the optometrist is done and finds out what error you have, that prescription goes to the optician, who is just a technician that shouldn't even have any contact at all with the patient. And so the ophthalmologist tells you what the problem is. If it's medical, they give you drugs. If it's surgical, they schedule you for surgery, send you to the optometrist for refraction. There are certain specialized refractions the ophthalmologist might have to still end up doing whatever, but your prescription then goes to an optician. And so people use these words loosely. They're not the same thing at all. The ophthalmologist is a medical doctor, the other is not. Yes, I think that answers the question. I don't know if there are any other questions.
There's one more question.
Okay.
The chat room. A child that keeps having eye ache and they've seen a doctor that told them they need to, they need to use cold water on the eye or something like that. I think I read that.
For eye aches?
Yeah. Let me see if I can still track that question.
Well, I don't know. Was he an ophthalmologist? That would be the question. Because if a child has eye aches, I don't understand. I don't know if cold water would be the solution. So, if a child has eye aches, you need to have it properly checked at an ophthalmologist. That's very important. Because I did list eye ache as a feature of a refractive error. So maybe this child is long-sighted or astigmatic. So eye ache would be prominent. And so you need to see an eye specialist, an ophthalmologist. That's important.
Ma'am, the question is, my daughter also complained of eye pain and the doctor prescribed eye drop and cold drinking water to wipe the eye whenever she complains.
No, I think you need to see an ophthalmologist, because the moment we hear complaints, we're already thinking about the possibilities, and I don't see that the cold water thing would be the thing to do. So please see an ophthalmologist. You have to know whom you're seeing. You understand? See an ophthalmologist. That's important.
There's also a question on, my sons sometimes wake up in the morning with secretion in their eyes. So a doctor prescribed ofloxacin eye drop. So I use this whenever I notice it. And my kids are 4, 6, and 1 years old.
Okay, so antibiotics are not medications that you should use in that manner. You can't keep using quantum doses of antibiotics every now and again. I mean, if it's an eye infection, it's an eye infection. If it's not an eye infection, it's not. So you shouldn't keep using, that's not, you're going to set up that child, to have resistance to that antibiotic. So again, I'll say the same thing, see an ophthalmologist so that it can be properly diagnosed. Sometimes when children are constantly having mucus, it's a sign of something else, not an eye infection. You shouldn't use an antibiotic, and it doesn't suggest. So it can, it can decipher what the problem is and get a good hold of what it is. Okay, I have another question. Possible cause of sudden redness in one eye and itching in both eyes in a myopic patient. Well, that would be, the person happens to be myopic, but these symptoms can happen in a person who is not myopic at all. And so if you have sudden redness in one eye and it's itchy, it could be that it's a child who already had an allergy. If the child already had an allergy and then, the allergy flares up and the child scratches a lot, it can get red. There's nothing stopping someone who already had an allergy from having a viral conjunctivitis superimposed on that allergy. And so if you have a viral conjunctivitis, which people popularly call Apollo, the eye can be red in an eye that was already itchy. And so that's why you need to evaluate this properly at an ophthalmologist. Thank you very much.
Okay. So I think that's all the questions. So we can call it today. We can call it today.
Yeah, so you give the vote of time.
We want to say thank you to all those who have participated today, those who came very early and those who came midway. Thank you very much. And we hope the next one that will be coming next year, by God's grace, you will all be there to also join us. And don't forget, we have a long journey to take for the next 12 months. So come on board. We want volunteers to join us. We really appreciate that. And you can always contact us on our website, our phone numbers, they're all there. Thank you very much.
Thank you.
Thank you.